Welcome everyone to our last Friday afternoon of Zoom meeting of the week. And thank you all for participating with us today. I'm Melody Anthony, the State Medicaid Director, and Traylor and I are working with individual provider groups to make sure that we communicate all the flexibilities that we have received from CMS, learn from you other flexibilities that you would like us to consider, and also answer any questions you might have about how these changes have impacted how you may bill us or communicate with us. And so I'm going to turn it over to Traylor.
Hi, good afternoon, everyone. I'm Traylor Rains, Deputy State Medicaid Director for the Oklahoma Healthcare Authority. So glad that we have a good amount of attendance today from this provider group. So as Melody mentioned, I believe this is our 7th webinar that we've done like this. You can go check out our website, okhca.org/COVID-19. We've created this COVID-19 response page to have all of our resources around reimbursement, resources for our providers. If you scroll to the bottom of the page, you'll see links to today's as well as the other webinars. So for instance, Monday we did physical, speech, and occupational therapy. So we have the recorded webinar and the complete Q&A reports from all those sessions as we have them. Wanted to just kind of go over the highlights so far that we've received flexibilities on. The Healthcare Authority did submit an 1135 emergency waiver request to CMS. We did that on about March the 20th. We received approval about a week later for those specific requests. There's still some outstanding requests that we've not received specific guidance on, but CMS is releasing information sometimes hourly, but definitely daily with regard to additional flexibilities that they're giving to all states around the various contracted provider types. So just some of those that we've are implementing now are if you're needing to bring in new providers and get them credentialed and enrolled through Sooner Care, we have flexibilities with regard to during the emergency period, we're waiving the fingerprint-based criminal background check, as well as the enrollment fee and the site visit. We're also allowing some providers, although not licensed in the state, if they're licensed in other states and other territories and you feel the need to bring in additional resources, we can enroll them during the emergency period. So the emergency period did begin on March the 13th, and it will go so long as and until the president declares that the emergency is no longer needed. But we fully expect that to be at least for the next month, so we're preparing as such. For those providers that are enrolled during the emergency period with the items waived that I just mentioned, if they choose to continue to be Sooner Care providers moving after the emergency period, they will need to go back and do all those the items that we have waived, including paying the fee, getting credentialed as you would outside of the emergency situation. We have also, one of the first things we did as an agency was to expand our codes that are reimbursable by telehealth and telephone. So we already had a pretty robust telehealth system, Medicaid reimbursement system in the state. But we expanded that to include a lot of codes that were not previously covered. For instance, we opened up a lot more behavioral health codes that had not been previously covered. Based on feedback we've gotten from this webinar, we've gotten great information from our provider community that has led us to open up additional codes. For example, physical and occupational therapy evaluations can be done via telehealth. We are adding a limited dental examination code that can be done by telehealth, and several others, including well child checks for children over the age of 2. All of this information can be found. Let's see, I'll share my screen again. If you go to our provider update page on our global messages, on a provider and then updates, global messages. If you scroll down, we make specific provider-specific globals. So you can see here for dental, we've added which code you would use if you're doing a dental encounter by telehealth. To reiterate, when we use the term telehealth, that is a two-way interactive audio-visual connection between the provider and the client. We have opened some codes for telephonic, but the telephonic codes are fairly limited outside of behavioral health. So for instance, I'll scroll down. One of the first things we did was open, let's see, the code set here. So we're allowing evaluation and management codes by physicians by telephone. The 99441, 442, and 443 are to be provided by physicians. The guidance surrounding this code and in the description is that this is to be used for established clients only. So if you're seeing a new patient and doing a new patient E&M code, that still needs to be done by two-way visual, audio, interactive video. For the other healthcare professionals that are non-physicians, if they want to bill a telephonic service, those would be available using the 98966, 67, and 68. Again, if there's any questions around how to build these codes or the parameters around them or the descriptions, you're always free to reach out to our provider helpline. The number is noted there. It's 800-522-0114. So other flexibilities that we've got been granted, and actually a requirement of some of the new federal legislation coming out, is that we are not terminating any member's eligibility during the emergency period. In fact, through the Families First Coronavirus Response Act, the federal government has given state Medicaid agencies an enhanced federal matching rate. So we're able to bump our FMAP up from regular program match in our Title 19 programs up by 6.2%. One of the qualifications, though, for a state to accept the 6.2 is that we cannot make any member eligibility adverse actions during the emergency period. For purpose of this piece, the emergency period starts on March 18th. So we've taken measures internally, including adjusting our system. We have pushed renewals for enrollments out by 60 days. And we're doing everything we can on our side, and we're cooperating with DHS on the long-term care population. But we do understand there might be instances where someone may lose coverage during this time. That is not our intent. And so I would say if you do encounter that situation, please reach out to member services so that we can ensure that client maintains their coverage at least through the emergency period. The only reason that we would unenroll someone is due to a member request to be unenrolled, or if they have left the state. So that's general flexibilities. We're also exploring, and the state is looking at, you may have seen, we are allowed to prop up hospitals and nursing homes in non-traditional settings in order to respond to the COVID emergency, such that, let's say if a nursing home starts identifying positive residents and there's a need for a quarantine type nursing facility, that facility could open up a separate location or an annex without having to go through the previous licensure requirements. It's my understanding the state is looking at a process to centralize that if the need is there, but we have received guidance from CMS and the ability to do that if we need to. We, specifically regarding FQHCs, we did request in our 1135 that, as you know, our state plan and federal guidance requires that in order to trigger PPS reimbursement, a service needs to be provided face-to-face. Regarding what we consider to be face-to-face, of course, is the use of telehealth technology. So using that two-way platform where you can actually see the client can see the provider. We asked for guidance in order to waive that requirement in order for FQHC to at least be able to bill fee-for-service for any telephonic services provided when telehealth is not an option. We didn't receive specific approval from CMS on that one to our request, but we have seen guidance that has later come out from CMS to all the Medicaid agencies and providers that we can allow fee-for-service reimbursement for FQHCs for those telephonic services provided to an FQHC client. Now we will maintain that in order to bill your current PPS rate, that needs to be done face-to-face using audio-visual. In order to do that and open up access to clients that may not have previously had those HIPAA secure connections, the Office of Civil Rights at the federal level is waiving enforcement of HIPAA specifically for the provision of those telehealth platforms or the audio-video platforms. So for example, you may be familiar with, there is the healthcare version of Zoom and Skype that is not like the version we're using today, that is more secure. You don't have to limit just to those platforms. So something like FaceTime on an iPhone, that would be acceptable right now. Skype, anything that's not public facing. The only thing that said is not approvable or appropriate to use is, let's say, a Facebook Live video or anything that it's known to be viewable by other members of the public. We did receive guidance that Facebook Messenger is okay because it's more private and it's not public facing. But again, we would defer to each facility and each provider to do their due diligence in ensuring that the security of the information being exchanged remains secure. So I will go to questions. Let's see, we have one. Will FQHCs be paid in counter PPS rate for the 99441 with the GT modifier? So these are the telephonic codes. And as of right now, no, the telephonic codes will not trigger a PPS rate, but you will be able to bill fee for service on that. We believe that we've set the system up appropriately to pay. But if you encounter any reimbursement issues or denied claim that you feel is an error, of course, as always, please reach out to our provider services folks so we can get that cleared up. So I think it's the clarification for telehealth medical services, Zoom, FaceTime, etc. Our provider provides a 99213. The FQHC would be reimbursed enhanced PPS encounter rate. Audio only is fee for service. Yes, that's absolutely the case. So the question on what revenue code should RHCs use? So you would bill as you normally would. Now I would say I don't have my finance folks on the line, but Melody, did we change anything regarding the revenue codes that an RHC would bill in response to telehealth?
No, it's exactly the same.
Okay.
Hey, Trailer, this is Aaron. I'm on.
Hey, okay, good. Thanks.
And I agree with Melody. Yeah, billing should be the same, but we are putting out some reimbursement notice guidance to, so look for that. If Jimmy hasn't already posted it, it'll be going up. It'll be going up soon.
Awesome, thank you. So Aaron, now that I know that you're on, did you notice that I missed anything in pointing out highlights specific to FQHCs that you'd like for them to know?
I don't think so. I heard, I got on a little late. I heard some of what you said, and I believe you've covered it very well.
Okay, great, thanks. So there's a question, well child checks greater than 2 are covered by telehealth. I think this is different from info presented yesterday. Yes, a good point. So we are updating daily. We actually made that change based on our call yesterday. So yes, beginning, and I'm not sure, we'll get guidance out there. I believe a global will be posted today. But yes, for children over the age of 2, we will cover those well child checks via telehealth. That's the audio visual. Again, another good reason to go check the Q&As that we've posted on the COVID-19 website, because some of the answers are more comprehensive and are more up to date rather than as compared to the ones that I've given in live webinars, because we have been able to go back and research and talk to the right folks to open up coverage. Now this might be a question for Aaron or one we can take back. So I was instructed to bill T1015 for our telehealth visits. Is this not correct? No, I believe that is correct. So your T code at the header level with a GT modifier for telehealth visits.
That's right. And Trailer, I will ask folks to refer to our website under provider reimbursement notices. There was a notice posted for telehealth at an FQHC or RHC on March 27th. Yes, the T1015 with the GT modifier for FQHCs, and just to confirm the 521 revenue code on line 1 with a E&M code and the GT modifier for RHCs.
Great, thank you.
So it is posted and publicly available.
So there's a question about what place of service should be used for the telephone 99441 and 442. The place of service is informational to us. It doesn't affect how your claim processes. You can use either the O2 place of service, which indicates that it was done by telehealth, or in office, I believe, which is an 11 place of service. Question, if an FQHC is enrolled, but we use a provider to cover that is not enrolled yet, will their services be covered or will you retro pay? So I would start, and I'll let others chime in, but I believe you would want to go ahead and get their application in currently, and we'll do our best to, I'm not sure that we can backdate it, but we'll explore the flexibilities that we have during the emergency period. I know that we are waiving a lot of the typical provider enrollment requirements. But again, to reiterate, anything that we have waived and during the application process during the emergency period, you would need to go back in and update that when it's over. If a visit starts as a telehealth visit and due to tech problems, the visit is only able to be completed by telephone only, can the FQHC still build a claim as a telehealth visit? That's a good question. Mel, would typical CPT timing rules apply to this? Would we apply like an 8-minute rule or the half of the service code time rule, possibly?
You know what? You may have stumped the panel with that question. That's the first time it's come up. I guess we never considered that that would be a scenario that we would have to go back and work through. But because it has been asked, I'm sure other people will want to know as well. So we'll have to get with our medical unit who reviews all of our claims and our coding for appropriateness and see if they have a response. So we'll put it on the Q&A answer sheet that'll be posted after this webinar.
Hey, we learn something new every day. So there's a follow-up. It says Medicare allows a telehealth visit that ends due to tech problems to be billed as 99201 through 99215. That's helpful. So we will look at that Medicare guidance, and hopefully that will guide how we cover in that instance. Yeah, we definitely understand tech problems will be an issue that'll be ongoing. Mel and I did 2 webinars yesterday, and right after the first one ended, my internet paused for about 10 minutes, so we get it. Okay, this is not specific to COVID-19, but has guidance been released on the modifier health center should use for same-day visits? I'm not aware, and unless Aaron is, that might also be one we have to take back to our group. So we will look at that.
Yeah, Trailer, I'm not sure either. So yeah, we'll have to circle back on that one.
Is there a minimum time requirement for encounters? So I would say all the regular rules for encounter apply. So whatever you're using now in order to trigger an in-person encounter would be the same if you're doing that encounter by telehealth.
Right.
So can a nurse practitioner or PA bill for telemedicine for psychiatry? If so, where can we find these codes? So we would defer to that individual scope of practice. And so if they have the right specializations to provide that service in person, the same thing would apply to telehealth. So telehealth is does not change the actual service. It's just a different way in which to deliver the service. So treat it as just for billing purposes, treat it just as you would if you were seeing that person in your office. Okay, does Oklahoma recognize G0071 as a secondary claims payment to Medicare? I'm not familiar with that code. If you could give me a descriptor. I know we have had questions around other insurance use different modifiers for telehealth when submitting claims, and our TPL department is on top of that. And you would just note that on your EOB whenever you submit it for crossover or for TPL. We have patients that do not have access to internet or smartphones. Can we still, as an FQHC, bill telehealth? So you could do telephonic services in that case, but you would bill that fee for service. So on the globals, we mentioned earlier that there are certain codes set up for telephone. So if your physician calls that are only allowed for an established patient, though, if it's a new patient, you cannot use the telephonic codes. But you could bill those telephone codes fee for service if the technology is not available. Okay, G0071 is virtual communication. So yeah, that would be very similar to what I mentioned a while ago, that our TPL department would see that come through and know that we would pay as if it was a covered telehealth service for us. So what is the advantage of using 99943 as opposed to 99213? So I think that's the telephonic code, right? So 99213 is an in-person E&M code. 9943 is for when you don't have access to the technology to do telehealth and you need to provide a service, physician services by phone. Is there a special form for temp enrollment of providers? I haven't seen that. I know that our provider enrollment folks have created new protocols and processes. So I would reach out to them as you usually would to enroll a provider, and they can walk you through their expedited process. Question around how would email communication be billed? It would not be. So we're still not reimbursing for email communications or store and forward either, I believe, which store and forward is when you take an image and you send it and back and forth. So we're not reimbursing for email communications. There have been questions about how to obtain client signatures. We got a lot of questions around that on our behavioral health session yesterday. So I would direct everyone, if you go look at the Q&As there, we have listed federal guidance on which various webs you can use, like DocuSign, to get patient signatures and which are HIPAA compliant and which you can use. We're also telling folks, use traditional snail mail. You don't have to have the client signature immediately, as long as it's in the client note at a later date and time, or the client's chart, that is. So if they send it back and you're not comfortable handling the mail, feel free to set that aside for a week and then go back through and process your treatment plans and other items that need client signatures at a later time. Are new patient visits allowed via two-way audio video or only in person at this time? You can use telehealth audio video for new patients. You just cannot do that telephonically. So there's another question about the same day billing modifiers. We'll look into that and respond to that in writing when we post that to our COVID-19 website. Let's see, how does fee for service codes reimbursement differ from telehealth? It doesn't, it's except you're adding a GT modifier. And Corey has added, if you look at the webinar chat box, Corey's added the link to our COVID-19 website in case you didn't catch that earlier. Mel, I haven't seen any other questions coming in about a minute or so. I'll kick it back to you if you want to have some closing remarks and wrap it up.
Okay. Again, thank you very much for joining us today. We do appreciate everything you're doing for our population, even prior to this crisis that we're all working through together. We will be more than happy to repeat this at a later time. If you would like, just reach out to Trailer and I, and we will set another meeting up. As I stated earlier, if you know of some flexibilities that you want to make sure that we are aware of, please get those to us and we will look at them for consideration. Again, thank you very much for your time. Have a happy Easter weekend.